I'll pass it over to you, and I think we can go ahead and get started.
Okay. Thank you all. Good morning, good afternoon to wherever you are. So I think we'll start today's session at the NHRC. We have an exciting lineup of panelists as well as a great speaker for today. And the topic for today's discussion is preterm cardiomyopathy. So I'll start by introducing myself first. I'm Deepak Lewis. I'm one of the neonatologists as well as a TN echo trained physician at Winnipeg in Canada. And we have three panelists joining today. First is Monica Sondhi. She is a staff neonatologist at Children's Hospital of Orange County. She's currently completing a one-year hemodynamic fellowship, and her interests are in the field of neonatal hemodynamics as well as different physiologies of congenital hearts. Our second panelist is Nicholas Williams, who comes to us from Australia. So he's currently working at Surrey Memorial Hospital in British Columbia. Previously, he has completed a certificate in clinician performed ultrasound, as well as he was a lead TN echo and focus person at Royal Prince Alfred Hospital in Sydney. And his interests are in the field of using technology to enhance learning, as well as clinician performed ultrasound. And our last panelist is Angelica Vasquez. She is a neonatal cardiac intensivist at Columbia University Medical Center in US. She completed her neonatal hemodynamics fellowship at University of Iowa, and she's main focus are in the field of cardiac and cerebral hemodynamics, as well as the use of non-invasive clinical monitoring tools in the NICU. So thank you for all the panelists for joining us today, and we look forward to an exciting discussion after the talk. Now on to our speaker, Abbas Hyderi, who's a good friend of mine. He's a neonatal intensivist for the Northern Alberta Neonatal Program and the education lead for the TN Echo and Hemodynamics program in the University of Alberta in Edmonton, Canada. He has research training in advanced cardiac imaging, and his academic interests include PDA, transitional physiology, and the use of multi-modal monitoring in the ICU. So thanks, Abbas. Welcome. And then we look forward to hearing your talk and the discussion after that. The floor is all yours.
Oh, thank you, Deepak. Thanks for that kind introduction. Good afternoon, good morning, good evening, wherever you are in the world. Thank you to the NHRC for this kind invite to this August Forum of Neonatal Hemodynamic Experts. It's truly an honor. Today we'll be tackling a controversial and a hot topic, preterm cardiomyopathy. I don't have any conflicts of interest, no endorsement of commercial products, but I would like to share some data that was done here, right here in Edmonton. And these are my team members, and Professor Lisa Hornberger's Chief of Division of Cardiology is our principal investigator. In terms of full disclosure, I will have a couple questions along the way, and we'll discuss the answers at the very end. Well, let's start with the real life case. These are real patients in our study. Names have been changed, Jack and John. You can stare at the echo. What I will give you a clue is one echo is normal and one echo is abnormal. Now, the task for you guys is to detect who is normal and who is abnormal, and we can talk about it in the discussion side of things. And you also may want to tell me why you think either Jack or John was abnormal and what you can do about it. So in the meantime, while you're thinking, let's move on to the slides. So today's objectives are, we'll review the literature of this topic, we'll talk about some definitions, understanding the unique cardiomyopathy related to extreme preterm birth, identify the impacts short-term and long-term, try to explore some strategies, and I try to keep this talk a little bit broad for my junior trainees and early career colleagues. Well, let's start all the way back from prematurity. WHO says that about 10% of the live births in the world are premature births, about 15 million annually. And this number keeps on increasing with premature births and increasing complicated pregnancies. With increasing advancements, this trend will only increase. And they have unique challenges at birth with sudden and sustained changes in loading conditions and added NICU inserts, which I won't go into too much in detail. But what is interesting is they have unique outcomes. And let's talk about the outcomes related to mortality. This is an elegant work done by Casey Crump. And 6 million births have been analyzed by this data. If you see the x-axis here, age on the y-axis is adjusted hazard ratio for death. And yellow is term and red is extreme preterm. And it's quite self-explanatory to see that the younger you're born, the higher the risk of all-cause mortality. But as we all know, it's not only the mortality that's important, it's the outcomes. And we often talk about long-term neurodevelopmental outcomes, but we never talk about long-term cardiovascular outcomes. But this is data again coming from 2.6 million live births and some very cool papers I've mentioned down there. The risk of cardiovascular related mortality is nearly twice as much. The risk of cerebrovascular mortality is twice as much. These are European data. There are risks of long-term cardiovascular, metabolic diseases. That's why some of the experts nowadays, they are suggesting preterm birth itself should be classified as a chronic medical condition. Well, the most obvious chronic cardiovascular outcome is congestive heart failure. So this elegant graph shows that very clearly. If you look at this graph, at the x-axis is the incidence of heart failure, and the y-axis is the gestation age at birth. If one is a reference for a term, extreme preterm is 17, i.e. there is a 17 times higher risk of cardiac failure if you are born ELBW. And it is dose response. For late preterm is about 1.5 times. For very preterm is about 4 times. So it's almost like a doubling and quadrupling effect you can see. And it's anybody's guess what will be the risk if there is another bar under 25 weeks. I would say it will be definitely higher. So in summary, we can say all preterms were not born equal. And the squaring effect is something we need to remember, at least in our ELBW counseling. I don't think it's now standard practice to discuss this data in an ELBW counseling. But one may ask, why this effect? Why are these preterm births getting cardiac failure? Thanks to Adam Lewandowski and his Oxford team who taught us what happens to that heart of the preterm young adult. This is a landmark paper published in Circulation that helped us open this Pandora's box. Look at this, about 100 patients, preterm born young adults at about 20 to 30 years of age. They are assessed by cardiac MRI, and young adults as well. If you look at the top panel, the blue box, the preterm born young adults, the LV mass was higher than the ones who were born at term, the green box. And the ones who were born at term, when you compare them to the older terms, they were same. So in summary, what did Adam tell us? That the hearts of the preterm born young adults are thicker, and this picture shows it very well. It's thicker, there's reduced end diastolic volume, there's reduced stroke volume, there is myocardial fibrosis, there is diastolic dysfunction. But what's also very important and often under-recognized is because the increase is about 19 grams on average, if you do the math according to the Framingham Heart Study, there's a 50% increased risk of cardiovascular event just because the left ventricle was thicker. Now, knowing the heart anatomy is not enough. We also need to know what is the physiology. What happens if these hearts are pushed to the limits of physiology? Well, Odero Huckstep helped us understand this in one picture. If you look at this, the x-axis is the peak exercise intensity, and the y-axis is ejection fraction, and the red are the preterms. So the more the exercise intensity, the lesser the preterm will manage, i.e. the ejection fraction will go down in preterm but somehow the terms, they would remain the same. In other words, there is a physiological stress when preterm born young adults are put through moderate to severe exercise intensity. Well, with so many studies coming out and all this data coming out for long-term cardiovascular outcomes, we need one study that can put all this together. So this meta-analysis helped us put all that together. It's a meta-analysis of 38 studies, about 3,000 live births. And if you can see, from neonates to infants to children have been arranged, and they actually measured the left ventricular E prime, which is a diastolic dysfunction metric. And in every age group, the E prime was lesser than their term counterparts, suggesting there is diastolic dysfunction starting from neonates all the way till adult if you are born extreme preterm. I won't go into this slide, but this is a beautiful picture showing all the things that we talked thus far in one slide. If anybody is interested, it's a nice article to read. But a couple salient points. In infancy, we talked about the heart rate, the heart size is smaller, their higher risk of pulmonary hypertension, hypotension. In childhood, their decreased exercise capacity, vasculopathy, aortic stiffness. In adulthood, more hypertension, metabolic disease. And once a pregnant woman who was born preterm gives birth to another child, there's a 50% increased risk of vascular etiology. So what is known as the spillover effect to the next generation. And this is carrying on. So I think by now, I hope I have convinced my audience that this is a unique cardiovascular pathophysiology and is related to extreme preterm birth. All we have to do is just find a name. Well, this article suggested one. So let's go over to the definition of cardiomyopathy. The American Heart defined cardiomyopathy very simplistically, that it's a disease of the myocardium where there is a dysfunction. Then there's many types of classifications. There's a primary, there's a secondary, but we won't go into that for today. All we want to talk about is if the cardiomyopathy, which is related to extreme preterm, is when there is a structurally normal heart, meaning in a structurally normal heart, if there was no other cause except preterm birth, that would be increasingly now called preterm cardiomyopathy. Now, there are some talking points that we can talk about, the animal data, human data, in NICU, out of NICU. We'll also talk a little bit about our own data. We'll talk about some diagnostic tools, basic science, clinical applications, potential approaches, and some directions. So very briefly, we'll touch on these points. Let's start all the way back from animal studies. This is an elegant work done by Jonathan Bensley in the UK about a decade ago. What preterm lambs who were about 34 weeks human equivalent, they were euthanized at about 9 weeks post preterm birth. And on the left lower panel, you see the myocardium. It's more whitish, there's less pinkness to it. And the preterm myocardium has more pink. And that is, the pink is actually the interstitial fibrosis due to collagen, and collagen takes up the hemotoxin and eosin stain. So they actually quantified that the preterm lamb had 7 times higher collagen. And not only that, the cells were thicker and there was cardiomyocyte hypertrophy. In other words, potentially there was less cardiac endowment and there was a cardiac hypertrophy as a secondary compensation. But then what about humans? Again, thanks to Adam and his team, he helped us look at the human myocardial fibrosis while we are still alive. He used a very unique technique that has been used in adult cardiac amyloidosis, where they use a cardiac MRI and gadolinium enhanced technique. So on the left lower panel, you see the blue dots are the preterm born adults and the red dots are the term born adults. You see the cells are larger and they're hypertrophied when you are born preterm. If you look at the top graph, You see there's myocardial fibrosis identified by this cardiac MRI in the preterm born adults. He also noted that there were diastolic dysfunction in the preterm, the blue graph versus the red, identified by echo and strain. So in summary, in this study, very elegantly, we saw for the first time a human heart, live human heart, having myocardial fibrosis and diastolic dysfunction and increased cardiac myocyte cell volume. Putting all this together, it raises a very big question. What about diastolic dysfunction? What is happening here? How can we deal with this? To understand diastolic dysfunction, we need to do a little bit of diastology review. I hope it's okay. I know there are a lot of expert hemodynamics on the call, but there may be a few trainees as well. So for the sake of everybody, I would like to do a couple refresher slides on diastology. So 4 big principles of diastology in extreme preterm: the extreme immaturity of the myocardium itself, there's less cardiac endowment, there's a faster heart rate, less filling, poor calcium handling, sudden change in loading conditions after birth, high afterload, shunts, preloads, and also very importantly, the LV is stiffer in the extreme preterm. They have the type of collagen is type 1, which is a very rigid one, and with time it changes to a type 3. And there's also poor springs, poor restoring forces. Now, we have seen this a million times from first year med school, but just we can stare at it for a couple seconds. I won't go into this. This is diastole, and this is systole, E and A and IVRT. And this is your Wiggard's diagram and your pressure volume loops. As they say, there's an elephant in this room, or rather a Titanic. But jokes apart, what is this? So this paper, Johannes Jansen actually said, titin plays a titanic role in diastolic dysfunction. So literally, it's a largest protein in the human body, and it also plays a very large role in the diastolic function of the human myocardium. And I'll go over a little bit about the titin. So it's basically a spring at the corner of the contractile unit, literally a spring, and there are 2 types of spring, a soft version and a stiff version. For example, if you have diastolic dysfunction, then you have the stiffer version, so it doesn't relax as well. And if you have systolic dysfunction, then you have the softer version. And the beauty of this spring is they can adapt based on the changing loading conditions from softer to stiffer based on the needs of the human at the time. And also it adapts over age, and you can see this from fetus to adult, it changes its morphology from a soft to stiff. But if anybody wants to know anything about diastolic dysfunction, I think a good starting point is this ASC guidelines from Sharif. And I won't go too much into details, but just big principles here. So there are 3 big principles in diastology. One is the active relaxation based on the actin, myosin, troponin, tropomyosin here. The restoring forces of the springs. This is a spring at its resting length. When you compress it, this is the L minimum. And then when you release it, it comes back to its resting length. So that is your restoring forces. And this is the lengthening load. So this gentleman is pushing the pressure in the left atrium, trying to forcefully open the mitral valve into a left ventricle that is very stiff. So that is the LA pressure. So in general, these are the 3 principles of diastology measured by these 5 pressure. And we usually use either an invasive or a non-invasive method to identify. Obviously, we're going to talk about non-invasive today. And in adults have it easy. They have only 4 parameters that they use to diagnose diastolic dysfunction: left atrial volume index, tricuspid regurgitation, left ventricle E prime, E by E prime. And they say that if you have more than 2 out of 4 positive, you have DD, simple. Whereas in preterms or infants or in pediatrics, we don't have our own guidelines. So we just fall back to the AAC adult guidelines. And then you can also differentiate whether the diastolic dysfunction was the early part of the diastole or the late part. And the common marker of early diastole is the E by E prime, and the common marker of the late diastole is the E by propagation velocity, E by VP. Now we took this diastolic dysfunction and our own program, we tried to study this in the preterm population at the Royal Alexandra Hospital in Edmonton. Lisa Hornberger was our principal investigator, and preterm babies were born about 27 weeks. At about 1 month of age, we looked at their echo data. We found that they were all having normal systolic function, but that reduced diastolic function. The E prime was reduced, the A prime was increased, the E by A was abnormal. So you see the preterm infants had diastolic dysfunction in spite of having normal systolic function. And what's also interesting is their atrial function was abnormal. The atrium was working harder to push blood through the mitral valve compared to the controls. There was increased filling pressure, but the E by E prime was increased in the preterm compared to controls. This was very interesting data, and it suggested that the preterms, they had altered diastolic dysfunction, but what's more interesting is it persisted even when they reached term, and it never became equal to their counterparts at term. And proving that there is something about prematurity that makes their heart stiffer and diastolic dysfunction. Now let's look at what other groups have done. This is an elegant work done by Nilkant in Australia. So ELBW infants at about 36 weeks of age, he not only showed us that these babies had diastolic dysfunction, but they also had abnormal shape. So the E by E prime was definitely abnormal when you compare it from preterm and term, but he also showed that the shape was thicker, they were more dilated, they were more spherical hearts basically in the face of a normal systolic function. Well, David Cox took it to the next step. He just showed the same thing in pictures. He used a cardiac MRI and he atlased the cardiac myocardial walls, and it's very self-explanatory if you look at this. The less than 26 weeks, they're more globular, more thicker compared to their term controls, more thinner or conal. And if you look at this graph, it explains it in numbers. If term is 1, extreme preterm is 1.6, the LV mass index, i.e. the left ventricular mass is 64% higher than its term counterparts. And then what did Nadine and Afif very intelligently took 200 babies and they went and checked them out at about 12 hours of age. And they said, okay, we have one group who are on CPAP, one group on invasive ventilation, and let's look at their diastolic function. And they found that babies who were invasively ventilated had poor diastolic function. They had E prime was abnormal, E by A prime was abnormal and was statistically significant. What is more interesting is they found that the babies who were having diastolic dysfunction and invasively ventilated, they had 10 times higher risk of pulmonary hemorrhage and also higher risk of IVH. Then it begs the question, was there something related between diastolic dysfunction, higher risk of invasive ventilation, higher risk of pulmonary hemorrhage, and IVH? Then is there a critical subpopulation who does this, and is there a critical window that we can target? So that's the question. Courtney Wall in Australia, he took the modified ACE criteria and he looked at the babies who had PDA. I won't go into this criteria. I've showed you the AAC guidelines, but he took this criteria and he applied to babies who had PDA. And he found that at about 1 month of age, if you're an ELBW, you had about 25% chance of meeting the LVDD criteria. And not only that, he showed that the prolonged exposure to PDA was associated with diastolic dysfunction. And this is very nicely showed in this graph. The longer you are exposed to the PDA, the higher risk of diastolic dysfunction as per the modified AAC criteria. So that begs another question, is there something about diastolic dysfunction that is contributed by prolonged PDA exposure. Maybe there is increase of left atrial pressure. There's a backup into the pulmonary capillary bed pressure, increasing respiratory distress, and worsening respiratory outcomes. Well, the question then became, could we not combine PDA and diastolic dysfunction to better predict respiratory outcomes? Well, Afif and group just did that. They actually combined diastolic dysfunction and the PDA into one metric, and they called it the score, the Al-Kafash score. So what is interesting is in this 5 variables, one is a diastolic dysfunction variable, which is the A prime, one is the prematurity, and the other 3 are hemodynamic significant PDAs. Not only the size, we know PDA size doesn't matter, is the size with the high volume with the pulsatility. So the combination of hemodynamic significant PDA, prematurity, and the diastolic dysfunction, he was able to plot it on the x-axis, the score, and the y-axis, the predictability of poor respiratory outcomes or death, BPD. And I think the cutoff was about 5 or 6 when it starts showing high sensitivity and specificity. So this is again going on to tell us that the babies who are born with a PDA, who are born early, who had diastolic dysfunction, did poorly in terms of respiratory outcomes. But we knew that from our follow-up clinics and so on, that they did poorly from our respiratory outcomes. What we didn't know is what happens to the preemies later on, like let's say 10 years of age or 10 to 12 years of age. So our group tried to look at this. So again, in Edmonton, in Royal Alexandra Hospital, we had extreme preterm babies who were born. We brought them back at about 12 years of age under the New Breath study, which was published by Joanna McLean in Thorax. And about 100 kids came back to us, and we divided them into 3 groups: microprems, less than 25, very prems, 26 to 28, and term controls. And then we tried to interrogate and see their echo data, their cardiopulmonary exercise data, and try to see if there was any difference. It was disheartening. There was no difference. Each child had about 200 echo variables, and it was really painful to do that many echo variables to see there was no difference. And this is the data. This is still in publication. I mean, in preparation for publication, we're just doing up the manuscript. The systolic and in the systolic and the diastolic function of the conventional echo, there was no difference, except if you see there's a small signal here. SD ratio was different between the term and the microprem. Although it could be something that is just a chance, so we didn't pay too much attention to that. And then we looked at the strain. There was no big difference, no meaningful data there. So we started to think maybe we should increase our sensitivity of our tool. So we went to a twist. So we use twist mechanics to identify the groups. Again, for the purpose of the broader audience, I'd like to 1 or 2 slides on twist. So twist, as the name suggests, is just a twisting of the heart, just an overview of cardiac twisting. This is a video which shows the twisting. As we all know, the heart has helical fibers arranged in the left hand and right hand axis. And when they twist, at the apex and at the base, the net force is this yellow line. And we can calculate the twist, its speed, its peak, and many variations of how the heart is twisting and untwisting. So twisting relates to the systole, and the untwisting relates to diastole. One of the problems of this technology, there is no common yardstick. There are many softwares. Each software has a different way of doing it. Each software has a own normative data. So we chose to use our own methodology. We actually published, our group published in this. And so this is from the same paper, and this is from our own patient data. So it's exactly the same. We could match what was the publication, the methodology part of it. using this methodology, we applied to our patients. And now you can see every parameter was abnormal when you compared the microprem with the term. For example, the microprem was twisting 8 degrees, and sorry, my apologies. The term was twisting 8 degrees. The microprem was twisting 12 degrees. So they were twisting 50% more. And they're twisting at, let's say, 85 degrees per second, whereas the microprime was 107 degrees per second. Again, they're twisting not only higher, but they're twisting faster. So they're kind of basically working harder to maintain the cardiac output and showing us a normal conventional echo. What about the diastole? Exactly the same. They were untwisting faster, untwisting higher. And not only that, the most important thing is the relaxation was poorer. See, the percentage of untwist at the mitral valve opening, it's simply a way of telling the relaxation, how much of the relaxation is occurred when the mitral valve is open. And if you see, the term controls had relaxed about 40% of its diastole, whereas the microprems could relax only about 20%, i.e., they are only 1/5 relaxed, whereas their terms were already 2/5 relaxed at the mitral valve opening. So kind of they are slow in relaxation. There's an impaired relaxation. And again, we show that in graphs here. So terms versus preterm, the SD ratio was different as we showed earlier. This is commonly seen in elderly hearts, commonly seen in mild left ventricular diastolic dysfunction. Then we also showed that it is dose response with your increase, with your gestation going smaller, lesser and lesser, your torsion and untwist becomes worse and worse. So there's a dose response. We showed that both in the twist and the untwist. Excuse me. So again, as I explained, the percentage of untwist, 40% and 20%. Our study could be summarized in 2 slides. On the left-hand side, if you see, the red graph is the microprems. They twisted higher and they untwisted slower. You see the twist, it was only 19% before the mitral valve opened. So there's this isovolumic pressure decline, or what is called the dP by dt, is abnormal. When you compare it to the terms, they twisted lesser and they relaxed better. So basically, the preterm, the microprems, were much different than the terms, both in systole and diastole. And this is very interesting, how that they relax, their poor relaxation. And this is the data from the myocardial fibrosis paper that I showed you from Adam Lewandowski. So our graphs match their diastolic dysfunction graphs. On the right-hand side, this is a graph that shows the exercise capacity and is inversely related. The preterms are the red and the terms are the black. So they're poor exercise capacity. Now, this is a busy slide. I won't go into the details of it, but there are 2 big concepts. When we compared our study for the rest of the world, we want to mention 2 things. When you're reading this data, you have to pay attention for 2 things. One is the gestation at birth of those patients is a 32-weeker is very different from a 26-weeker. Remember the squaring effect, the doubling and quadrupling effect. Those 2 hearts are not the same. Number 2, the birth eras, if you're born in the 70s and 80s, is not the same as you're born in the 2000s, because we all know the surfactant and the nitric and the high frequency, all of that changed in the last 30 years. So they're 2 different populations. Anyways, finally, we'd like to summarize our study that teenagers born extreme low birth had normal systolic function. The diastolic dysfunction became manifest using twist mechanics, and the diastolic dysfunction exaggerated with greater prematurity in exercise. We like to think it's just like a duck. We are calm on the outside, but underneath we are paddling furiously to stay afloat. And we speculate, is this a compensatory mechanism? But what's more important is, if you join the dots, this becomes really interesting as to why this preterm born adolescent is similar to an elderly heart. If anybody can recognize this elderly gentleman, we'll talk about it in the discussion. He has contributed to something in pediatric cardiology, but was not recognized for 35 years. We'll talk about it. It's very relevant to today's talk. Anyways, so the ELBW hearts are very similar to an elderly heart because this is the natural progression of the untwist. With age, your heart becomes stiffer and your untwist becomes higher. So somehow the ELBW's heart is like an old man's heart. In other words, there is a bold statement we can make here that when you're born ELBW, you have a correction factor. For example, if you're born, let's say 25 weeks, when you are 40 years of age, your heart is about 65. There is a correction factor that has to be incorporated. Currently in the medical literature, that is not there. This is the Framingham risk calculation for 10-year cardiovascular mortality. You can see clearly prematurity is not mentioned as a risk factor, although we have data from more than 6 million live births that it is a risk factor, but it has still not gone into mainstream calculations. But all this is fine, but can we use this in the NICU? These advanced tools can be used. It's very limited data in very early days. Ashling and Afif did some work on torsion in the neonatal period. They took 50 babies, ELBWs, in the first week of life. They did torsion and twist, and the red is the preterm and the blue is the term. They found that with increasing days of age, the diastolic dysfunction got worse, and they speculated it was because of the sudden increase in postnatal loading conditions, and it got worse. Adam James, he did the same thing in the 26-week stable infants, about 1 kilo of age. And one of the things that he was mentioning was that the frame rate to heart rate ratio was about 80%. If you maintain that ratio, it becomes feasible to do a torsion mechanics in the preterm population in the first week of life. So this is your strain, basal and apical strain from Adam's paper. And this is the diastolic twist and untwist, both at the apical and the basal region. And his data is shown here. But what's also important is it's not only that his data is here. When you compare his data with others, and our papers are here, it is different. And this begs the bigger question is, can we compare apples to apples? And that has, as I mentioned earlier, that has been an issue with the twist mechanics. That's why the group in Norway came up with this technique where they said, instead of going into the twist, let's go into the myocardial work itself. Let's find out how did the myocardium work, like we would do in the invasive cath lab. But they did it non-invasively, which is very interestingly. So they about 100, 120 infants were born at 27 weeks. They came back at 27 years of age, and they looked at their hearts non-invasively with an echo, and they could draw out their pressure volume loop as if it was a cath lab. And they could identify the myocardial work. And they actually showed us data that the preterm born young adults had abnormal strain compared to the term, and the myocardial work was abnormal compared to the controls. Although they suggested that the trend was there, but it didn't meet statistical significance. It was 0.08 p-value. Nevertheless, this is early days for this technology. I think we are in the era of non-invasive precision medicine, and I don't think we can get any more precise than myocardial work without putting a catheter in the heart. Now, all this is fine, but the question is, what can we do about it? So I'll take you through a couple studies where they've done some treatments. So this is a very elegant work done from McGill, Marianne Bertagnoli. She took 2 sets of rats, and both of them are induced by oxygen-induced cardiomyopathy, and one was treated with water and one was treated with angiotensin receptor blockers, losartan. And they were euthanized, and they saw the babies, or the rat babies, so to say, who received angiotensin receptors blockers had a thinner left ventricular posterior wall and lesser LV mass index compared to ones who got water. So the water rats were thicker. You can see there's lots of fibrosis, but the ARBs was lesser. In other words, by using ARBs, you could actually remodel and reduce the preterm cardiomyopathy in the rat model. Another fascinating work, again by Marianne from McGill, proof of concept here. I won't take you through this entire biochemical pathway, but it's interesting to see the renin-angiotensin system. As we can recall, there are two arms to this renin-angiotensin. One is the pro-fibrotic and one is the anti-fibrotic arm. What she said is, when you block the pro-fibrotic pathway and let the metabolites drain into the anti-fibrotic pathway, and she gave those rats alamandine, oral alamandine, she could replicate the same findings what she saw on an ARB. In other words, it's a proof of concept that by modulating the renin-angiotensin axis, you can reduce the preterm cardiomyopathy. And this is without alamandine, lots of fibrosis, and with alamandine, minimal fibrosis. Now, this has been shown in animal models where you modulate the renin-angiotensin, you can prevent preterm cardiomyopathy. What about humans? Steve Abman and Peter Morani from Colorado used ACE inhibitors in later infants. For example, these are some case reports. 28-weeker who was a chronic lung, went home, came back on oxygen, was diagnosed to have pulmonary hypertension. They were started on nitric, and the baby worsened. And it was full of fluid. In fact, when they took the child to the cath lab, they found the problem was the opposite. It was a diastolic dysfunction problem, and the LA was dilated, and there was water, or there was pulmonary edema in the pulmonary capillaries, leading to worsening. So the baby was now put on ACE inhibitors to relax the LV diastole and went home, recovered. So Steve Appman has shown that this is a common recurrence, about 8 out of 33 in his cath lab. We see this phenomenon. What about this index? Arvind Sehgal from Australia showed this very elegantly in this graph. The x-axis is the mean velocity, which is a contractility index, and the y-axis is the afterload index, the end systolic wall stress. So this relation. So what he told us that if you had a higher afterload, then you have a lower contractility, i.e. when the heart is pumping against a wall of bricks, it's not contracting well enough. And the reverse is true. And he showed us in numbers. So basically, this stress velocity index was shown. But then if you go and find out where in the world people are doing stress velocity index, the Japanese have been doing this for the last 15 years. And this is the outcome data from Japanese networks. The red is the Japanese, and this is the rest of the world. They definitely outcomes are better than the rest of the networks. But if you go and analyze their TNE protocol and you look closely, ELBW infants get echo, and if they have poor contraction, as measured by the velocity index, MCVFC, and if they have an excessive afterload, then those infants are now treated with a dilator, or the classical LMNOP of our med school, where we treat adult heart failures with Lasix, morphine, oxygen, nitrate, positive pressure, and propped up position. So literally they use the LMNOP if you met this criteria of stress velocity index, or what they called as afterload mismatch. Then again, they replicated the study, very similar. I won't go into the study. Again, the same thing. If you had high afterload, if you fall in the A zone, you got nitrates. If you fall in the I zone, you got dobutamine, because you want to support the pump rather than the afterload. Now, Toyoshima from Tokyo, Katsuaki Toyoshima, he did this very elegant study in which he took ELBWs and he did serial echoes, 8 to 12 hours, I think, for 5 days. And he divided into two groups, the infants. The group with the triangle are the ones who had grade 3, grade 4 IVH, who had pulmonary hemorrhage, who had PVL bad outcomes. And the ones with the round were the ones who had good outcomes. What he found was at about somewhere on 24 or 30 hours to 60 hours, the afterload suddenly increased in the groups who had bad outcome, and their contractility decreased at the same time. It begs the question, there's something about that window. If you remember Cote d'Ivoire at about 12, Cote d'Ivoire as well as Ashling and Afif at about 12 hours of age, they told us there was left ventricular diastolic dysfunction. There's something between 12 and 24 hours where potentially there's a window of a target where we can get in and try to modulate this. And that is the concept that is emerging. Is there a target window? And then now, what did they do? So before 2000, they were using the standard of care, but then after 2000, they changed to the stress velocity approach. And what did they find? They found the IVH dropped from 22% to 4%. Pulmonary hemorrhage dropped from 20% to 7%. And not only the short-term outcomes, the long-term outcomes also changed. So this is a paper about 8,000 microprems, 22 weeks, 23 weeks, and 24 weeks. And the survival was about 75% in this subpopulation, and the survival free of neurodevelopment outcome was about 78%. The outcomes are not bad at all, but I know in Iowa from Patrick's group, their outcomes are even better. And I'm not telling that it's because of the stress velocity they're getting these outcomes. It's a bundle effect for sure, but it's something to look into. Putting all this together, so far we have not found a solid evidence what is the treatment for preterm cardiomyopathy, except this randomized controlled trial, which was done by Alan Lucas in the 80s. Alan took two groups. One is preterm infants who were formula fed and human milk fed, apologies. And this RCT was done 25 years ago in Cambridge. But Adam Lewandowski brought them back at 25 years of age and used cardiac MRI to now assess the LV diastolic volume index. And you can see the blue box are the patients who had received formula versus the orange are the ones who received human milk. So their heart has improved the fact that they had got human milk. But they didn't improve as much as if you were born at term. In other words, the preterm cardiomyopathy can be improved if they were given human milk at birth, but they still will have preterm cardiomyopathy compared to their term colleagues. And this is a concept that started us to think, is there something in the breast milk that is protective? Afif and group and Phil Levy and Amish, Adam, all of them came together in this study with about 100 ELBW infants. They compared with the term controls, and they said, if you got 4 weeks of human milk, we'll take you in the study and we'll check your echo at 1 year of age. And they found there was a linear correlation: is the more milk you got, the better the cardiac function measured by strain. But what's also important, they found that it is the receiver operating curve was 87%, which is very correlative. So in other words, the bottom line is there was something in the breast milk that was cardioprotective and improved their cardiac function. So the old saying that the breast milk is the liquid gold is probably still true. Now the question is, where do we find gold? If you go into the breast milk literature itself, there's this new emerging literature in the last 1 to 2 years where it says the human breast milk has a cardiac remodeling effect. There are a couple metabolites, or starches, I should say, human milk oligosaccharides, that blocks the angiotensin II receptors. They are known as 6-silolactose and 3-silolactose. And interestingly, these are now FDA-approved lacto-engineered milks that are commercially available, and these are known to block angiotensin receptors. And it's anybody's speculation, it's probably these oligosaccharides that cardio model and change the preterm cardiomyopathy, both in the rat model showed by Marianne Bertagnolli and the Alan Lucas RCT shown by Adam Lewandowski. And I think for now, as we dig deeper, we don't have an answer, but one thing is for sure, the search continues. We should find an answer to this phenomena. And in summary, what I can say is the one sentence summary is the adult born preterm have increased mortality and morbidity, but we don't have a proven therapy except breast milk, and there are some emerging signals of hope. Thank you again for your time. It was a pleasure. Happy to take questions.
Thank you, Abbas, for that fascinating talk. I would request the panelists to join as well. And I think we'll take any questions from audience to have a discussion. So just to get the discussion going, Abbas, I had a few questions when I kind of read about this topic. So from some of the studies, it appears like the preterm heart, as they get into adulthood, it's more dilated, whereas in similar studies, they also find that there is an increase in the wall thickness and it's more hypertrophied. So is it possible for us to classify this like cardiomyopathy as, is it kind of a hypertrophic cardiomyopathy, or is it dilated, or is it kind of a mix of both?
That's an excellent question, Deepak. Thank you. So, and this is probably what I was trying to allude when I was talking about the differences in the literature. And I'll go back to that slide, Deepak, if you don't mind.
Sure.
Yeah. So this slide kind of answers your question a bit. So if you look at this gray boxes, they have increased left ventricular mass index. The Adam Lewandowski's study, 66 versus 55. So that group had thicker LV mass or LVH. Now, if you flip into the modern era, the blue table, you see they're actually the opposite. You see, there is, let's say, 39 versus 44, meaning two eras are showing us two different results in the two different directions. So there's a lot of back and forth in the discussions of all these papers as to why this phenomena is happening. Either really is it left ventricular hypertrophy, or is it the left ventricle is lesser? So the most relevant explanation is that it was likely the change in the practice and the gestation. As I mentioned, this is 32 weekers and this is 26, 28 weekers. Maybe at that time, it was a different NICU practice. And at that time, also the babies were bigger. They were 32 weekers. Whereas if you're born at 26 weeks, what happens is you have less amount of time in utero, what is classically now called as the less cardiac endowment. That means you don't have enough time for your cardiac muscles to be developing in utero, because ex utero, you don't have cardiac myocardial development. You only have myocardial hypertrophy. There is no increase in number. So the babies who are born very preterm, 26 weeks and all of these, they have less time in utero, so they have less cardiac endowment. So this endowment is the answer to this question in the literature, why there is a difference between the left ventricular hypertrophy and the dilated smaller babies. And this is an ongoing discussion. I don't think we have an answer for now. Only with more and more literatures in the new era, this will become more clear. I hope I answered your question, Deepak. Thank you.
Yeah,
Deepak, it's Nick here. If I can jump in, and Adam in his editorial following the Cox results showing using the MRI to show the thicker walled left ventricles, he does point out that this is going to be influenced by postnatal steroid use, as well as invasive time on invasive mechanical ventilation, which again, as Abbas has said, is clearly changed in those cohorts from the 80s to more recent times. So there's definitely a difference in those practices that are occurring that are going to impact on the degree of left ventricular wall mass and thickening.
Thanks, Nick. That makes sense.
Just looking at the Q&A, I don't think we have any questions so far.
Oh,
Abbas.
there's a couple. There's
Oh, sorry.
That's okay. So one question was, could you tell us a little bit more about the different reasons that babies are born preterm and which ones are more likely, is it known which ones are more likely to develop diastolic dysfunction in these ways?
Thanks, Tina. No, I didn't touch on that too much because it will become a very long topic. But when Cote d'Ivoire and Ashling and AFIF, when they did the studies, they tried to keep the study clean. Even our own study in Edmonton, we kept it clean. We excluded IUGRs, we excluded twin-to-twin transfusion, we excluded diabetic. So we tried to keep it as clean as possible. Obviously, if the infant is born, let's say severe IUGR, there's already increased afterload in utero, and there is already cardiac remodeling occurring in utero. So when they are born ex utero, that is only going to get worse. So definitely IUGR is a very classical scenario in this. And trisomy 21 is another evolving new category here. And there is a bunch of categories where we see this. I mean, that's another different talk on what are the subtypes of preterm cardiomyopathy.
There was also another question about vascular function and what the role of vascular function is in cardiomyopathy.
Well, to understand that question, as I showed in that pictograph, I think it's here, the vascular function becomes more manifest in childhood rather than infancy. If you see here, in infancy, it's not as much as a big issue, at least in the neonatal population. As the child grows, the afterload gets worse. Basically, the LV is pumping against increased SVR, and slowly this aortic stiffness index gets worse, and the carotid arteries diameter gets thicker, so this vasculopathy starts setting in. And that is probably the beginning of the adult metabolic disease, the adult hypertension, the adult metabolic ischemic heart disease, and the LVH that ensues when they are adult. I think this is it's a chronology. As you can see in this graph, it starts with the dysfunction, it ends with the structural insufficiency, and it probably ends further into failure at the very end. So it's a continuum.
Thank you. One more based on the questions that we received. Could you sort of summarize what you think are the best measurements that people should be doing for diastolic dysfunction in the preterm infant when they're acutely in the NICU? And then based on all the things that you discussed, besides feeding them breast milk, are there other recommendations that you have in terms of treatment?
Yeah, thanks, Tina. Very tough question. Okay, let's start with that. Besides breast milk, okay, so we cannot argue against breast milk. The sooner, the better breast milk, irrespective of the baby's condition. I think we all can agree on that. And the number two you asked is, what can we do about diastolic dysfunction? What metrics? Well, there's very little data to answer your question from a literature standpoint, but if I use, again, Ashling's and Afif's data, at 12 hours of age, they went in and they did diastolic dysfunction. They found the E by A prime was what they used. And our own data from Edmonton, we used E by E prime. I think the adults have it easy. Cote d'Ivoire used the modified ASE definition. He used basically these 4 parameters. But the adults, they use a different number, E by E prime more than 14. Cote d'Ivoire used E by E prime more than 18. And then he used LA volume index more than 1.5 mils per kilo. So basically, I think if you were to choose one article to start your practice on assessing LV diastolic, you would probably do Cote d'Ivoire's paper, which I showed. That's number one. Number two, of all the parameters, I think E by E prime is definitely the parameter people are more and more looking at, especially for an early diastolic marker. And we don't do a lot of propagation velocity. We should probably do, because that's a marker of things are too late. Now, E by VP is a very sensitive marker for late diastolic problems, and it's been matched with CATH data. I think the answer to this question, Tina, is, to be very honest, is we don't know, and we're just struggling and just looking at one or two papers, observational, low quality evidence papers, and trying to make sense of it. The real answer to your question, Tina, is we need to study this. We need to study this, and we need to come up with our own neonatal ACE guidelines and publish it. And actually, we need to actually do a pilot feasibility trial and identify the target population, identify the target window. And I think we need to collaborate with experienced centers like the Japanese, and they have excellent, like Australia, like, Arvind Sehgal, and they have excellent understanding of stress velocity. We collaborate with them. We do a multinational small pilot feasibility trial, and then start looking at the answer. I think that's the real answer. Other than that, this observational studies cannot answer your question accurately, at least.
Thank you so much. I wanted to see if the other panelists have, are willing to share their approach. What are you guys doing right now to assess diastolic function in your practices?
I can jump in. I'm obviously currently in Canada and Surrey, and I've only been working here for a little while, so I can't really talk about the practices here. But what I can talk about is back in Australia in Sydney, and obviously we work closely with Kurt DeWall and have been working with him. So I guess we have been following some work by Professor David Osborne back in the early 2000s that was showing poor contractility early on. And Abbas, interesting to hear you saying that you think the critical time period is between that 12 and 24 hours, whereas David showed that poor contractility at 3 hours, so that 3 to 6 hours scan was really critical to predicting low SVC flow as a marker of systemic blood flow at 24 hours, and those babies went on to have IVHs. So we have been, and the practice have routinely been scanning these babies, all babies kind of less than 26 weeks at 6 hours, to look for, I guess, poor contractility as a marker of, that preterm cardiomyopathy, that ability, that poor heart to cope with those changes and rapid changes in the afterload, and have been treating those with dobutamine that have had low or poor contractility to try and compensate that. I think what's really interesting with Adam's study that used those two cohorts of formula versus expressed breast milk is just how that we can have an influence, on a long-term influence on the cardiac, the myocardium, by simple interventions early in life. And I think that's the key, is that potentially what we could be doing in the first few days of life can have profound long-term implications. And whether it is ARBs or whether it is other interventions to be putting in, I think that's the key to take home here, is that we do need to get better at recognizing this and understand that these extremely preterms, and I guess another little side plug is that we've got to remember that a lot of these trials have excluded the 22, 23 weekers. So those babies, and Abbas, it was great to see that in that new breath trial, you really stratified for less than 25 weekers, but we really need to understand that those 22, 23 weekers probably have even a more unique physiology and changes. So I think it's key that we start recognizing this and look for it, and echo what Abbas was saying, that we just need to get better at looking and researching into this and being more aware of it.
I had a question. Obviously a symptomatic baby, kind of around our chronic lung disease definition of about 36 weeks, those babies will get echoes in our institution looking for chronic PH. do in all your institutions recommend or just routinely screening all premature babies at a certain gestational age for signs of diastolic dysfunction? And if so, are there interventions that you guys do in an asymptomatic baby, knowing that they're at higher risk before going home?
Monica, is this for me?
Anybody, but sure, you could start.
Yeah, in our institution, we just screen at 36 weeks. We actually are screening focused on pulmonary hypertension, more on the right side of the heart, right? I don't think we are focusing on the diastolic dysfunction at 36 weeks. So that's a short answer to your question.
We would not be looking for diastolic dysfunction at 36 weeks at this stage.
I'd say that we try to screen, but we've also had more of a focus on the right heart at Columbia. But I will say that during training in Iowa, there was an emphasis on doing at that 36-week pulmonary hypertension CPH screen for those babies. We were starting to pay more attention for diastolic markers, and there, I know that group published specifically babies who had signs of diastolic dysfunction in the context of systemic hypertension. They were starting to implement the use of some ACE inhibitors in some of those babies to help control their their hypertension, but it would be in the context of having diastolic markers. I don't think that that's totally evidence-based, but it's more based on the physiology and thinking about what might help in terms of modeling for those babies.
So Angelica, just to come in here, you said interestingly, when you have pulmonary hypertension and you had systemic hypertension in a BPD population, that's when Iowa, they start using some ACE inhibitors. It's interesting because remember the data that I showed from Steve Abman from Colorado, they use the same thing. In babies who are having systemic hypertension and diastolic dysfunction, ACE inhibitors probably has a role in that population.
Abbas, can I ask you a question similar along those lines? And I guess it's a provocative question, but do you think the next trial or role for this, so we all know those babies that have had prolonged mechanical ventilation, have had exposure to a large left to right ductal shunt, have, you scan them and you see quite a dilated left atrium with a large LAAO ratio. Do you think there's a role for ARBs there? Or should we trial that?
You already started your question by saying it's a provocative question. I actually have a slide, what I think we can study. And I'm really interested to push this space forward with collaboration from all of you. Okay, sorry, my apologies. All right, so I don't know what you guys think, and we can discuss this offline, online, but I think a few things we can definitely start doing. One is we definitely need to talk to our families about this ELBW data, that we have to include it in our counseling. That's number one. That's easy because the data is there. We just have to tell them. In terms of studying this space, I think we can start with like a feasibility trial, something like the Smart PD has done. And I go on again to repeat that we need to collaborate with pediatric cardiology, maybe go to Japan and do a site visit, or go to Melbourne and see what Arvind is doing. And all the experts in this area collaborate, and then we come up with a feasibility, multinational feasibility trial. And then we pick our patient population, and you can pick 26, 27 weeks. And in terms of intervention, what I think we could do is definitely the breast milk. We probably have to do Q 8 to 12 hours of TNE to catch the window. And you said, Nick, that David Osborne's study, about 6 hours, they're already starting to see the differences. In the study from Japan, they also started to see the differences early on, but I thought 12 hours was like a clear window when things start becoming different. So anywhere between the 6 to 12 hours window, if we start doing echoes, and if the infant has any sign of LV diastolic dysfunction, large PDA, respiratory insufficiency, and we all can come up together with a collaborative protocol, we can start them on low dose nitrates. So that N there, which is a asterisk is low-dose nitrates. And I looked into literature. Have we done low-dose nitrates in preterms? Yes, we have. There's, I think, good studies, good case reports when we have a UAC or any radial outline. The fingers are ischemic. We use nitro patches. And the dose of that drug is actually more than what the Japanese are using. So it's not that the extreme preterm cannot tolerate. It's probably we just have to start at a very, very low dose. The Japanese are using 0.1 to 0.3. We can probably use at 0.05. All you need is that a little bit of touch of relaxation, and probably the pulmonary capillary bed pressures can be a little bit lesser. And definitely the PDA, you have to go after it. Otherwise, it's just going to add to the left ventricular diastolic dysfunction, as Cote d'Ivoire showed us. So this is an idea, and I'm happy to hear from all the panelists and speakers and audience if we can collaborate and move this space further.
Sure, sign me up.
Thanks, Nick. Oh, one more thing. In terms of follow-up, I think our networks are all collecting neurodevelopmental outcomes, but nobody is collecting cardiovascular outcomes. I think at some point, people should start collecting that. And I talked about the preterm correction factor has to be incorporated in the next round of calculations.
Jokes aside, I think this is a great idea, Abbas. I think where you're going to struggle will be potentially with your, intervention number 2 there, catching the window and having enough people around who can competently get the measurements required from TNE. But if you can overcome that hurdle, I think that this is definitely something worth doing, even if that is the intervention itself. It's just to have a look and get some more data on these longitudinal data on these extremely preterms, and including those really small, those tiny babies.
Agreed, Nick.
I wonder, Abbas, whether the platform of NHRC might be right. You can tap into that and see if you can get a group of people who are interested and circulate. I'm not sure how how they can coordinate, but I'm sure there are many sites and investigators who are part of this platform. So to kind of get interest and build up a group where you can kind of investigate this further. There's one more question about one of the audience members saying that it's a great talk. What's the impact of diastolic dysfunction on IVRT in preterm babies?
So IVRT, it's interesting that it goes both ways. So if you have a mild diastolic dysfunction, your IVRT is prolonged because it takes a long relaxation. And if your diastolic dysfunction is worse, then it becomes lesser. The IVRT becomes lesser, becomes a pseudo normalization. And if it becomes extreme diastolic dysfunction, then it becomes very short. So IVRT, all types of IVRT can be seen in the spectrum of diastolic dysfunction from mild to severe. So that's why IVRT alone cannot be given so much emphasis. So that's why the diastology experts, they're telling not only IVRT, you have to look at decel time, mitral valve decel time. You have to look at the mitral valve A duration. You have to look at the pulmonary vein AR duration. So you have to put these 4 parameters together to understand whether that child or that infant is having diastolic dysfunction, yes or no. So IVRT alone will not answer that question, because all types of IVRT can be seen in all types of diastolic dysfunction, unfortunately.
And then I think there are no more questions. Just one last question. So we know that there are epidemiologic studies showing the adult onset of cardiovascular disease among this preterm population. And now, as you showed nicely, Abbas, there are a lot of studies showing that there are all these cardiac changes that you could diagnose using MRI or echocardiography. The question is, how important is to link these two, right? I don't know whether we have data showing that young adults who have these changes in the heart, whether they go on to finally, I think we have data from other populations saying that all these changes are high risk for kind of ischemic heart disease or heart failure in the future. But do we have any of that data among the preterm population showing that with this cardiac changes, they are going to have those kind of outcomes? Or is that the link between the two? How crucial or how important is that to show that all these changes in the echo markers eventually would lead to all the outcomes that we are talking about?
Yeah, I think I showed that. I think the Huck-Step study, and I showed that with increasing or prematurity, so the more premature you are, there are more risk of cardiac failure. For example, I think that slide which I showed with the 17 times increased risk of cardiac failure if you're born less than 28 weeks. And I would say if you're born less than 26 weeks is probably more than that, definitely, the squaring and the doubling effect. So to answer your question, Deepak, definitely there is high risk of cardiac failure. When there is high risk of cardiac failure, there's high risk of death, cardiovascular death, and cerebrovascular death.
Yeah, my question was like, do we need to link the changes that we are finding in the 20-30-year-old population to those outcomes? Has that been shown, or is it not really needed at this point from all the other studies in normal adults? Right, like if you have at 20 years, if you have these echo changes, does it mean that okay, that person's risk at 50 or 60 years for cardiovascular outcomes are going to be much worse? Is that already known? Or
I don't know if there is known. The only best data we have, Deepak, is Adam Lewandowski's cardiac MRI data. And in that data, he used patients in the 30s. So I think to answer your question, we know answer till about the 30s. If your question is what happens to them when they are 50s or 60s, if that's your question, the answer is no, because this is an evolving subject. Maybe in the next generation, when these adults becomes 50s and 60s, then we'll know what happened to their heart. But we only have data till about the 30s because that's the best data is Adam Lewandowski's data, which is, I think the oldest patient in his data set was 35, 36 old. So definitely less than 40. Yeah.
Any other last minute comments from any of the panelists before we conclude?
No, just a fantastic overview of the preterm cardiomyopathy and the role of diastolic dysfunction. I think we're probably only just starting to get an understanding of this, and it's probably even more complicated than what we think. Kurt DeWall is starting to look at blood speckle tracking and showing in these preterm babies that the way that blood then travels through the heart following these remodeling is completely different. So that's something as well that we need to take into consideration. So thanks, Abbas, for your review and overview of this.
I have one answer to my question. Nobody discussed this. I'll go back to that. Okay. So this person, nobody answered this question yet. So he is actually Kawasaki, Professor Kawasaki of Kawasaki disease. I think why he's relevant here, because he diagnosed Kawasaki in 1961, but Nelson textbook did not put Kawasaki disease on its textbook until 1992. So there were 31 years went by where children died of Kawasaki heart disease, and the Western literature did not recognize this as a condition. It is provocative, but it also tells us that just because we are not having easy access to literature from one part of the world doesn't mean that disease doesn't exist, or are we wasting time by not investigating this? Because the reason I'm bringing this is the Japanese have already approached this for the last 15 years, but it is not a mainstream approach in the rest of the world. So I think it's relevant here. Maybe we are waiting too long to start studying this aspect, and maybe there is some way we can help these children moving forward.
Okay, thanks. Fantastic work, Abbas, and thank you to all the panelists and the audience for joining today. Thank you.
Thank you so much for this great talk.
Thanks, guys.